Farhana Amanullah. Farhana Amanullah is a board-certified pediatrician working in Pakistan since 2003. She established the pediatric TB program at the Indus Hospital, Karachi in 2011 that is now the largest private child TB program and referral center in Pakistan. Farhana is a member of the core group of the WHO Child TB subgroup and has helped provide technical assistance and training in Indonesia, Thailand, Kenya, and Pakistan. She is also a member of the WHO Guideline Development Group and the Sentinel Group for DRTB in children. I will now turn you over to Dr. Amanullah for the presentation. Thank you.
Hello everyone, this is Farhana, all the way from Karachi, Pakistan. I hope everyone can hear me well. Thank you, Evgenia, for your introduction, and I'd like to thank the Sentinel Group for arranging this webinar series. It has been, the lectures have been fantastic, and we've all learned from each other's experiences and expertise. So my talk today will be on managing child contacts of drug-resistant TB patients, and I will be sharing with you our program data from Karachi, Pakistan, as well as our plans based on the collective wisdom of what we know so far about treating contacts of DRTB patients, and how we hope to improve upon our contact management in Pakistan. Here we go. So the outline of my talk is that I will first go over, I will start with the importance of screening vulnerable contacts of DRTB patients and why it should be a priority. Some examples of successes of preventive therapy where that have been used globally, and what the situation is like for TB in Pakistan currently. I will introduce to you the Indus TB control program and what our contact management experience has been so far. And then I will switch to what our plans are for improving on contact management and including preventive therapy in our contact management as of the near future. I will also share with you our contact management protocols and how we plan to go about constructing a preventive therapy regimen. Of course, there will be challenges, and I will also discuss with you the expected challenges and what we feel can be solutions to those challenges, and then finally the conclusion. So, why should we screen contacts of drug-resistant TB patients? There have been many publications and studies that have looked at the prevalence of disease among contacts of DRTB patients. And we know that this is a high-risk population, and particularly young children under 5, and who are at higher risk for developing disease faster and can develop fatal forms of disease. So, doing contact investigations around children who are in household contact with a DRTB patient makes perfect sense. Again, this is a disease. If someone develops it, it is a protracted treatment. It is a complex disease. There are many months of injectables with our current regimen. The treatment regimen is not child friendly at this point. Again, the efficacy of the treatment is also in question at times. Treatment outcomes are not that fantastic, and it is a very expensive treatment. So we are looking at a disease that if we are not able to prevent will be costly in the long run. So a program for prompt evaluation, monitoring, and preventive therapy for household members is absolutely necessary to avert these preventable cases of an expensive disease, a complex disease, and all the other things I mentioned earlier, and preventable deaths, because in advanced cases, this is this can be fatal. So, what is the current guidance for preventive therapy for DRTB? Well, the current guidance is really watchful waiting. And there are many arguments about, giving preventive therapy to, say, a child who may not go on to progress to disease. What about the toxicity of that treatment? What about the unclear efficacy of the treatment? These drugs are not that fantastic. A child could have a susceptible strain, which is very likely in a setup such as, say, in Pakistan, where there can be multiple source cases. Resistance propagation is another question people put up. Like, what about resistant propagation amongst mycobacteria and other organisms? What if, months of giving a fluoroquinolone in a child, what would be the outcomes of that? Low risk of disease progression if left alone? Yes, in some children that or some contacts that is the case. And it is definitely not a current priority in high TB burden setups and in a setting where the resources are so poor that you really need to get at the actual cases. There are children and adults that are going undiagnosed that are not reaching effective therapy. What about getting to that lot instead of going after a group of children or a group of individuals that may not even develop disease? So it's not a national program priority at this point. So um, with that backdrop, we move to what we know from observational studies that have been done. Yes, randomized control trial data is not available yet. They are planned, but it will take time for those to come out. But what do we know from the wisdom that has that that is already there from certain programs? And this is a slide from Dr. Scarf's presentation that he presented at the Global Consult meeting in April in Dubai, held by the Harvard Medical School group. And this is actually from April 2015. And in this is a study that was published um, um, the regimen was well tolerated. Few children developed TB or died if they adhered to therapy, and their proposal is that the provision of preventive therapy to vulnerable children following exposure to MDR TB should be considered. And what else? A recent a webinar about 2 months ago, which with by Dr. Bergstrom and Dr. Bamra, where they were able to the CDC was able to control two very important MDR TB epidemics in the Chuk Federated States of Micronesia, and they found that when they treated the contacts for latent TB infection, they were able to control the epidemic almost completely. And then no contact treated for MDR latent infection developed TB disease, which is phenomenal, which means that this works. They found good completion rates. They found that the regimens were safe and well tolerated, also by children. And they found that the LTBI treatment by directly observed therapy is doable. Again, this was a well-funded and a very well-structured program, and there was a lot of a lot of commitment from the people who were the locals in Chuk, and that those were one of the reasons why this program worked really, really well. And I think a very important statement that I want to make right up front is that you can protect 500 children from DRTB at the cost of treating one DRTB patient. So the cost of giving medications to one DRTB patient for the entire regimen would can protect you can for the same price you can protect 500 children or give preventive therapy to 500 children, which is in itself shows how cost effective this could be. So, since I'm going to be talking about Pakistan, I would like to give you some perspective and tell you the situation in Pakistan. So, Pakistan is a country with a population of 182 million. The TB incidence rates are 275 per 100,000, and prevalence is 342 per 100,000. These are again notified cases. So what is known, and we know that there are high rates of under notification and underdiagnosis, particularly in children in setups like Pakistan. The MDR TB incidence among notified cases in 2013 was very low HIV prevalence rate. So if we look at the situation and look at Pakistan in the overall scheme of things, it stands at number 4 in the high TB burden country list for both TB as susceptible TB as well as MDR TB. And here is the duplicate. Okay, so so in this setup, in this kind of a high TB burden setting, and in most situations low resource, we have the Indus Hospital TB program that of which I am a part. The Indus Hospital is located in Karachi, which is an urban megacity. It's a coastal city in Pakistan, and has a population of 23.7 million. So it's a huge city. Um, the Indus Hospital, it provides free tertiary care to all individuals, and of course, the Indus Hospital program is the same. So it's free workup, free visits. So um, all care is provided free of cost. It has enrolled and treated over 14,000 susceptible TB patients to date since inception in 2008. And the pediatric TB program has been particularly, it has done well in the sense that it has enrolled and treated over 1,500 children to date with TB, and it is a big childhood TB reporting center from the private sector, which private sectors are known not to report children, unfortunately. So this is a clinic, the TB clinic, which is an airborne infection control facility, and it is very well designed for a high burden. So there really is no question of stigma or anything like that, and the people are very open to wearing masks there, which is a great thing. Now, to put into perspective the sort of cohort or the sorts of patients that we are seeing with drug-resistant TB at Indus, again, to kind of give you an idea of what kinds of contacts in the same context we would be seeing. So, the program has enrolled and treated over 2,400 DRTB patients since inception. Initially, it was the main referral center, so we were seeing a lot of referred DRTB patients, and a lot of them were advanced cases that have been making the rounds and had been sick for years and were finally able to access GDF, quality assured drugs, free of cost from Indus. And now we have expanded and have branched out to other rural areas within Pakistan, and have other facilities, and the patients have care has been moved to those regions as where they live. So despite that, we have over 150 new patients enrolled every year. The treatment success rate is around 76%, which is fairly decent considering that this includes cases that, as I said, are referred from different parts of Karachi and Pakistan. Time to culture conversion has reduced from an average of 8 months to 2.5 months, so things are improving, and there is low HIV prevalence, which is a good thing. So I want to point out this particular graph, which looks at the age and gender breakdown or distribution of DRTB patients at the Indus PMDT. And if you look at, since I'm a PEDS person, I'm going to look at the 5 to 14 year age group. Now that doesn't look like a very impressive number, since it is only 5% of the total DRTB caseload. And it's interesting that 20% of these patients were diagnosed through contact investigation. So they were picked up earlier and treated effectively. So that's a good thing. However, we still have most of our patients are, so I would say, are actually culture proven. So these are children who are culture proven DRTB patients. And the other important thing, so what I'm trying to say is that I think we are only seeing the peak of the problem here, and not. I'm sure there are a lot of patients in this category as well that we are not quite getting at. And contact investigation is one way of reaching to this population. And the second important thing that everybody must be looking at right now is this big number of females from the 15 to 24-year age group. So this is nearly 30% of the entire caseload of DRTB at the Indus hospital. And the important thing about this particular age group is that these are females culturally in Pakistan. Females are more likely, young females are more likely to be housebound. They're more likely to be home, taking care of perhaps the young children in the house, and less likely to be going to college or school, and are an important group that may be transmitting disease to young children. Again, there are cultural barriers to having these females tested, and there are many issues around that, around the whole gender disparity in this particular set of people. But the main thing is that this is a high risk group that may be taking care of children or be having children of their own, and hence making contact investigation and contact evaluation around young children of DRTB households all the more imperative in this particular cohort. So we have done some work on our contacts, the child contacts of DRTB patients, and this was published in 2014 in the IJTLD, and we found that there was high TB prevalence in children exposed at home to drug-resistant tuberculosis. And this this in itself is again a point towards the need for contact investigation, the need for earlier evaluation, and prompt and treatment, effective treatment children, and also to protect the ones that are not yet not developed disease. Further, when we look at in a more updated version of the study that I just showed you, we found that TB disease prevalence in that study was about 7%, and it is 9% as it stands currently. And TB infection among these child contacts of DRTB patients is as high as 33%. Another important finding was that nearly half of the children, these are contacts, these are well contacts, um, in living in a household with a DRTB, current DRTB patient. and nearly half of them were severely underweight. Again, this is a problem in the peri-urban and urban slum locations in Pakistan, that we have high rates of underweight and malnutrition. But that also makes that particular child all the more vulnerable to acquire infection and then progress to TB. Again, I also wanted to put some data from our IPT program, which unfortunately is not as successful, because for as IPT programs across the world are, again, for the reasons being that follow up rates, poor initial evaluations, and all of those things. But however, it was interesting to see we also found high rates of TB disease among the less than 5-year-old contacts of drug susceptible TB patients. So that is also an important finding. Again, trying to build the case for contact management in our setup. This is a photograph from a typical household where our health worker is interviewing the contacts of a DRTB index patient. And so there is a strong community base to the program, which is one of the reasons for its success. Now, despite this great contact management program that we are running, there are many, many challenges and many issues with it that an individual is diagnosed with drug-resistant TB, is started on treatment. A healthcare worker goes to the household and looks at all the children and all the contacts that are in their household and does a symptom screen, and then encourages the symptomatic individuals and all the children to come to the clinic to be evaluated. We still do not see, many families do not present for evaluation. Again, because that is not a priority. It is difficult to get the large families, which is typical of the Pakistani setting, to come in to be evaluated. Poor follow-up rates is, after seeing them for the first time, you usually never see them again, which is also fairly typical. And this is with a PMDT and a DRTB program that is quite well run, and it is quite has excellent counseling services and very good social services provided as well. So in a lot of circumstances, although we say that it's active case finding, it really becomes passive. And with their symptoms. So that means really that the contact investigation wasn't as effective as you would want it to be. And it is, in my definition, it's a passive case finding. No treatment of DRTB latent infection, because that is the current guidance, is that you wait and watch and you look for evolution of other things. No preventive therapy for under 5-year-olds, again, because this is not the current guidance. And we also see high rates of severe malnutrition. So again, a setup where, where the likelihood of, if infection has been acquired, there is a greater chance of developing. So after this, the global consultation meeting for managing child TB, for managing contacts of DRTB, household contacts of DRTB patients, that was conducted in Dubai in April 2015, the consensus statement of which will be out soon. We found a lot of collective wisdom um, and a lot of encouragement, really, to go ahead and start a pilot in the Karachi setting and see how things go. And to so in a setting such as ours, it is really not smart to wait for another 5 years before we can actually have the results from randomized control trials, and we can have some concrete guidance as to should we give preventive therapy or shouldn't we? Is it smart to wait that long and have all those children acquire disease, or is it better to start now and to expand and do a pilot and see how things go, and then perhaps inform national policy, at least within the region. So there was an overwhelming consensus that there should be a registry or all the contacts within that household should be entered into a register. And that would be one of the things that we would do with our more improved contact management program. Trained health workers will perform household contact investigations as they do now around consecutively diagnosed MDR-TB patients until reaching the target number of 100, because our pilot is we are going to limit ourselves to 100 households or 100 DRTB patients. All contacts will have a symptom screen, height, we lose a lot of kids and a lot of patients in TST is placed and they don't come back to get it read, or they don't they slip through the cracks and they don't get a TST done. So if we are looking for latent infection and this is our only marker, then that is an issue. And if say a healthcare worker who is trained to place a PPE can do so in the household and then go back and read it, it would be ideal. But again, it's not we haven't worked out how to do that yet. So evaluation, who will be evaluated for disease? Under 5-year-olds, less than 5-year-olds for TB disease. Now it's really important that children who are under 5 and in direct and in close contact with a DRTB patient, a lot of times they do not show the typical symptoms, and so regardless of symptoms, they need to be evaluated for TB disease with something more test X-ray, and it's important to go ahead and give them preventive therapy. Then it's absolutely imperative that you rule out disease first, and that is one of the reasons why um, the people have been hesitant to promote preventive therapy. So yes, it's important to rule out disease in this age group. Contacts 5 years and older will receive a TST. Contacts with a positive TST, which would be 5 millimeter or more in duration if the individual is underweight or malnourished, or 10 millimeter or more in duration if the individual is normal weight. Investigations to rule out TB disease in the TST positive group would be important again to rule out active disease. Any child, adolescent, or an adult. So this the it again we are not 100% sure if we will be looking at adults yet, but we are definitely going to be looking at the child and adolescent contacts. But I have added or adult because under ideal circumstances we would like to have the adults evaluated also. One or more suggestive symptoms for TB disease will get investigated to rule out TB. Then, so some management algorithms for the 0 to 4-year-olds, history, physical, height, weight, MUAC, and further investigations as indicated. And if they are found to have TB disease, then yes, they will be started on a DRTB treatment regimen based on the index patient's TST. If they are completely well and everything is negative, then TB disease is not detected, and then they will be candidates for DRTB preventive therapy. For the older age group, the 5 to 15-year-olds, they will undergo a symptom screen and a tuberculin skin test. If one or more TB symptom is present, then they will be worked up for TB disease. And if the the workup is positive and they're diagnosed with TB, then again they would go on a DRTB treatment regimen based on the index patient's DST till the point that their own DST is available to guide further improved therapy. And if the workup is negative, then they would be followed closely. If there are no symptoms and the DST is positive, and if they happen to be immunocompromised, say with they're found to have HIV or DM, these are for older individuals, or they're malnourished, then we would want to go and investigate them for TB. And if TB disease is diagnosed, then they would go on treatment, and if it is not detected, then they will be diagnosed to have DRTB infection, and they would have the treatment for that. And if the individual is completely well and there are no symptoms and the DST is negative, then there would be symptom screening every 3 months till the following 2 years. So this is the plan for the pilot and how we want to go about it. Who will get DRTB preventive therapy? Again, all children under 5-year-olds who have been in whom TB disease has been ruled out and they are well, and they would receive preventive therapy. All children, adolescents, and adults with LTBI or latent infection, as I defined earlier. I have also added with question marks all malnourished children, adolescents, and adults, all people living with HIV, all adults with TM. Ideally, these are also individuals who are susceptible and at high risk and should be treated for LTBI, but not at this point in our pilot. Follow-up, household contacts will be followed for 1 year from the time of initial evaluation. For healthy contacts with no infection, a repeat TST at 3 months would be advised. Preventive therapy and LTBI treatment would be given for 6 months. Um, the directly observed therapy and monthly questionnaires by field workers, and the forms have been adapted from the CDC study. They're really nice forms, and we went ahead and adapted them for our study, for our pilot. And physician evaluation would occur 2 monthly during the treatment period. Now, constructing a DR preventive regimen is not as simple or as easy as it sounds. It's actually can be quite complex in setups where there is pre-XDR, XDR, and where oftentimes we diagnose the patient based on expert MTB results. So we have based on the observational studies that we have and the data that we have from other groups, two drugs that the index patient is sensitive to, so levoflux and ethambutol or high dose INH. Again, we are not doing mutation analysis of the organism of the mycobacterium, so that could be a problem, but we are thinking of doing LPAs and looking for INHA mutation, and in those individuals, perhaps high dose INH can be instituted. Again, this is something that needs to be confirmed. Moxifloxacin in cases of Uflox resistance. We do have a fairly high rate of fluoroquinolone resistance, which makes it's about 30%, which makes our situation particularly complex because preventive regimens have a fluoroquinolone based on fluoroquinolone. So what do we do in a setup where there is high FQ resistance and our preventive regimen's backbone is FQ? So after some brainstorming, it was suggested to use oxyfloxacin, as some other groups have done. In situations where we only have expert MTB BIF results to go by, and an individual has been diagnosed and we're waiting for BST results, or it becomes another issue that we wouldn't know that if the patient is the patient BIF monoresistant, it's VXDR or XDR. In those situations, again, it is difficult constructing a preventive regimen for a household contact. And what do we do for preventive therapy for XDR? Again, to not have an answer for that at this point. Duration of therapy for TB infection would be for 6 months. And what are the expected challenges? Well, the expected challenges, as we know, are going to be are likely to be poor to treatment adherence and completion rates. Drugs are not child friendly. There are multiple drugs. Levofloxacin are still in pill form. There will be so a lot of support and a lot of counseling would be required. Programmatically, this would be programmatically difficult, and more resources would be needed to put in the social and support aspect of the program. Poor follow-up rates is another issue that we have had so far in our contact management programs, both IPT and the DRTB programs. And that is another issue that we expect, and we have kept our follow-up strategy fairly stringent, so that we expect that to be a challenge as well. Adverse event monitoring. We don't know yet. A study of this kind has not been done yet, and we don't know how the particular population, in terms of adverse events. Although our outcomes from our DRTB treatment group in children have been fairly good, in the sense that adverse events have been a minimum. Potential reinfection risk, again, this is a high TB burden setting, and there may be the chance of reinfection from other source cases. So those issues remain. Some proposed solutions, as at least in terms of the programmatically. So our team is quite good at coming up with solutions for running programs effectively. And one of the solutions that has been proposed is to have a dedicated contact management team. So this would be a team with a health worker, a driver, and with a vehicle that is big enough to actually bring in an entire household for evaluation if need be at a time. And their sole job description would be to get in people, families who have an individual with recently diagnosed with drug resistance. And this is something that is quite doable. We have the facility of setting this up, and of having this contact management team. That main purpose is to link up and to really save families the worry of trying will be this will be a fantastic community-based strategy if we can get it going. And this would also be it would also be their job to bring them in for follow-up visits. Additionally, incentives for households. We do have a great social support group for our DRTB patients who get food baskets on a monthly basis, and other social services, including rapid medical advice and other how should I say, um, treatment for malnutrition and food supplements, etc. So similar incentives can be incorporated for households who are having all their contacts evaluated. Again, this is a project that is kind of ongoing, and we are building on it. So finally, to conclude, community-based drug-resistant TB contact management that ensures early disease identification, effective treatment, and prevention is essential to achieve zero TB deaths in high DRTB countries. Again, watchful waiting may not be the smart approach for setups such as ours in Karachi, Pakistan, where DRTB numbers are high, transmission is ongoing. I think just looking at the economics, as I said, and someone did the math for this, that uh, the cost of medications for treating one MDR TB patient, which is around $5,200 can fund the preventive treatment of almost 500 children, and it can prevent disease in 58 children. So imagine the cost saving is right there. I mean, it's not even it's quite obvious, and implementing such a program is doable and ultimately cost effective. As I said, it would require a lot of program strengthening, additional programmatic resources, and but having said that, it has been done by others, and it is truly and it is possible. It does require a strong community base, which we are hoping to achieve in our pilot in Karachi. And let's see how that goes. And thank you. That brings me to a close of my lecture for today. And let me see what the questions are so far. Okay, so the first question is how long would you wait between contact and initial TST? 6 weeks, 8 weeks, 12 weeks. Thanks. So the initial TST would be done soon after the index patient is started on treatment. And the reason for that is that usually DRTB patients have been sick for a while. We found in our cohort that there was the average period of sickness or illness for some of our patients was as long as 2 or 3 years. So this is not, the disease has been around for a while. So we don't expect that this is something new, and we want to repeat TST in those who are negative. The second question is, give a clue to the possible incentives. I would follow the best buddy approach. Okay. So the possible incentives that we have thought of would be more targeted towards families. The first incentive was, of course, providing support for transport. So individuals that are bringing in, say, 8, 10 family members to reimburse their transport costs. That and if we are going and we soon hope to start our contact management sort of transport team that will be dedicated to do that. So hopefully we will be able to bring the patients in and have them dropped off to their homes by ourselves. So hopefully that will be sorted right there, because that seems to be a big barrier to a lot of patients that just cannot afford to bring in this big group of people to get evaluated. Another incentive that we have shown that works really well is providing food baskets. Food baskets for our DRTB patients have been very successful. They also kind of enable the DRTB patient to be not sucking up resources in the house, but actually providing food to other household members. So that has worked extremely well in our program. And perhaps we can use incentives such as additional food baskets for households evaluated. Top ups, etc., that have worked well in our setup, where mobile phones and the use is really really important to people. So that is also another incentive that works. Uh, 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 yet another incentive is quick link up for medical services, because a lot of times free medical care and services are not that easily approached, and people have to wait in long queues and lines. And if if contact families can have uh, sort of a quicker access to medical care as an incentive built um, into the contact management program, that is also another thought. The person who asked this question commented, right, I agree on early DST. Patients are already sick when diagnosed and would have transmitted some infection. Yes, agreed. Have you thought of any methods to distinguish between patients who are drug sensitive and pre-MDR rift monoresistant? Is this for individuals who are sick already, or are we talking about, um, well, the only way is through doing a DST, doing an expert test and then a DST. Um, so I'm not sure how to answer that. Are you using enablers? How much would they attribute to the success of the, hang on, um, how much would they attribute to the success of the program and improving adherence? What is your experience? By enablers, I'm assuming you mean treatment supporters. Yes, we do have treatment supporters for each DRTB patient. So there is a treatment supporter going in and also doing DOT.
Thank you so much for the presentation. We will make this webinar available on the DRTB Training Network's website, as well as the slides.